stuff going on. Also, as Barry said, so please put questions in the Q&A box. We love questions. We want to make this interactive. We want to make this useful for you all who are taking time. And also, if anybody's listening asynchronously, if you have questions, please feel free to email me. So let me just sort of turn on some slides. And so as Barry said, so I do have research funding from the National Institute of Mental Health, the Hood Foundation, and some other foundations. I don't have any industry funding for this or any of my work over the past 20 years. I want to start my talk sort of telling you about sort of two prototypical children who I've taken care of, hundreds of over the years that kind of inspire my research. I am a clinician, so I don't have a PhD in addition to my MD. My research has been inspired by questions that really concern me as both a pediatrician and a child psychiatrist. And so Jack is 5. He has fatigue, fever, joint pain, a swollen belly, and bruising. Someone says, wow, Jack's not right. We should do something. Let's take him to a provider. The provider sees that his liver is big, spleen is big, and Jack's pale. They order a biomarker, a complete blood count, a CBC, something we've all done hundreds of times, thousands of times for our patients. We've all had ourselves. They notice that Jack has a very low white count and he has a very high percentage of blasts, immature white cells. So the symptoms plus the biomarker, the CBC, lead to a specific early diagnosis and mechanism-targeted treatment and a better prognosis and better outcome. Specifically, so Jack has ALL, the most common form of childhood cancer. And while that's not a good thing, I would never wish cancer on anybody. The reality is our understanding of the mechanisms of childhood cancer have vastly changed childhood cancer from an absolute death sentence in the 1980s till now, where the 5-year survival for the most common forms of leukemia and other cancers are over 95%. That's what the graph on the right shows. Kids with cancer go on to even become pediatricians and child psychiatrists and things like that. Because again, people said enough of our kids dying. Let's get all of our kids with cancer in research. Let's learn more and more about their illness experience, that their individual illness experience can transform how we take care of these kids. On the other hand, Gabby, an 8-year-old who is very moody. At times, Gabby can be irritable, angry, and destructive. At times, Gabby can be sad, sullen, and want to die. At times, Gabby can be hyper, silly, and goofy. At 4, Gabby was brought to therapy for anger and not following directions. At age 6, they started an SSRI for treatment with anxiety plus therapy, but there was some out-of-control behavior. Gabby got hospitalized. Unfortunately, we don't have the test to determine if Gabby has bipolar disorder or honestly any other disorder. We don't have the biomarker to guide what treatment Gabby needs. What's her prognosis? Will she live to be 15, 20, 25? What's her risk for suicide today, in 1 week, in 1 month? Does she need to go to the ER? Does she need to be hospitalized? And so it's this dichotomy between the Jacks of the world and the Gabbies of the world that has inspired my research in the PD Mind program, where we are trying to learn more about the brain and behavior mechanisms of our most impairing child psychiatric disorders for more accurate and effective diagnosis and more active and effective treatment. We do a lot of stuff with computer tasks of cognition and emotion, brain imaging, detailed assessments of symptoms, and that's kind of been my professional work for the past 2 decades, which we're going to talk about a bit today. We really have 3 learning objectives. We're going to talk about the importance of irritability from childhood to adulthood. We're going to talk about prior relevant research, including work on bipolar disorder and disruptive mood dysregulation disorder. And then we're going to talk about how to diagnose and treat these disorders. There are 10 take-home points, which I'll highlight, 10 practical things that are useful, I think, to everybody involved with outpatient care of kids and adolescents. So to start with talking about irritability. So irritability is the top chief, #1, outpatient complaint for children and adolescents. This is data from Dr. Kolashaw, who looked at data not just from the 80s, but also from the 2000s, sort of highlighting the fact that irritable mood is the #1 complaint for both biological males and females, both from the kids and from their parents. So it's not just sort of this study, there have been other studies. So the Irish health behavior study, over 10,000 kids, show that, again, the number one complaint in outpatient mental health, over 43%, was irritability and bad temper. Studies in the ER have also shown that it's the most common reason kids are brought for psychiatric evaluation. It's not just a problem for kids. Childhood irritability is associated with substantial impairment into adulthood. So Dr. Stringaris looked at a study called the Children in the Community Study, upstate New York, about 630 kids examined at multiple time points, found that adolescent irritability in the mid-teens predicted middle of life, age 33, increased risk of psychopathology, including major depression, generalized anxiety disorder, and dysthymia. Interestingly, irritability did not predict bipolar disorder, nor did it predict access to conditions. It also wasn't just a psychiatric disorder thing, it predicted actual functional outcomes. So irritability as an adolescent predicted decreased income and decreased educational attainment of the adult. Dr. Pickles from the Isle of Wight study in England, again, over 2,000 kids followed for multiple decades, showed that adolescent irritability was a significant risk factor for adult suicidality. So for many kids, irritability is not just a phase, it predicts substantial problems into adulthood. Irritability is not specific to any disorder. So while Oscar the Grouch is kind of cute in many ways, there are more than 10 different disorders involving irritability. And unfortunately, we don't have a scan, a test, a questionnaire that specifically identifies which disorder or which disorders an individual child may have. These disorders include a manic episode in kids or adults, major depressive episodes. For children, there is an age-specific modification that their mood doesn't have to be depressed, it can be irritable. Oppositional defiant disorder, again, sort of refusing to sort of comply with parental or adult requests. Generalized anxiety disorder, so worry about lots of things, not any one particular thing. PTSD, it's an associated feature of ADHD. It's implied in conduct disorder. It's involved with intermittent explosive disorder. It's an associated feature of autism, and it's central to disruptive mood dysregulation disorder, which we'll talk about in a bit. So take home point number 1 of 10, irritability is a big problem. It's the most common reason kids are brought for psychiatric evaluation in outpatient or ER settings. It's an explicit diagnostic criteria or associated feature for multiple disorders. It's associated with significant impairment in adulthood, including worse psychiatric health, but also decreased academic and employment functional ability. There is no biomarker or scale to guide clinicians in determining what disorder or disorders an individual child with irritability does or doesn't have. There's a need for better treatments for irritability highlighted in several review articles, including a Cochrane meta-analysis. And so the result is over or misdiagnosis potentially for any and all of these conditions, including data indicating that there are more than 28% more children medicated for ADHD over the course of about a decade. Some studies showing that about 20% of children discharged from psychiatric hospitals across the US in the early 2000s were diagnosed with bipolar disorder. Autism has increasingly high prevalence, including 1 out of 68 children, 1 out of 42 boys. So I would argue that irritability is not just the most important child mental health problem, because it has sequelae into adulthood. And it's not just the most important mental health problem, because it's not just about mental health, it's about lack of educational achievement and poverty. So irritability actually may be the most important health problem across the lifespan and across all different types of systems. So having talked about the importance of irritability, learning objective 2 is to talk about prior relevant research, including stuff about bipolar disorder, and then how did we get to DMDD? So take home point number 2, much research on irritability comes from work on bipolar disorder. And so when I was finishing my training and seeing lots of kids being diagnosed with bipolar disorder in the early 2000s, which was sort of after the ADHD epidemic and before the autism epidemic, there were a couple things driving controversy on bipolar disorder. So one was this idea of, is bipolar disorder an episodic disorder with a distinct onset and offset that was distinguishable from baseline euthymic or normal mood? Or is bipolar disorder a chronic condition with rapid alteration between mania, depression, and even mixed episodes, even within a single day, but happening so often it's happening on most days? Another controversial issue was can kids in bipolar disorder, is it mostly an irritable mood, or can kids actually have euphoria, meaning an abnormally elevated and expansive mood? And while there are a lot of different research ways to sort of address these controversies, I became a postdoctoral research fellow and then an associate clinical investigator at the National Institute of Mental Health in the greater Washington, D.C. area with Dr. Ellen Liebenluft, who basically said if this is what the controversy is, episodes are not, euphoria are not, you can separate these into a standard 2 by 2 table and figure out what's really going on. At the extremes, the research with Dr. Liebenloft involved kids with narrow phenotype bipolar disorder who had full duration episodes. Those episodes involved euphoric mood different from their baseline mood. And the idea is, so narrow phenotype, meaning a strict interpretation of what is mania, so that everybody would agree these kids had bipolar disorder. At the other end, kids with severe mood dysregulation, kids with chronic non-episodic irritability, who never had distinct episodes and who never had euphoria. And the idea was, do these two types of kids, do they exist? If they exist at all, what is their longitudinal course? Meaning, do they end up mushing together or do they remain distinct? Also, what about their brain and behavior mechanisms? Again, distinct or shared? So I'm going to share some of the work that happened over the course of 10 years, some of which I was involved with, some of which I wasn't, to give you a sense of what we found. So one study that came early on from Melissa Broadman at NIMH was looking at the prevalence of this severe mood dysregulation, this chronic irritability. Dr. Broadman used the Great Smoky Mountains study, which is a longitudinal study in the Carolinas. What she found was that overall, the prevalence of severe mood dysregulation, chronic non-episodic irritability, was about 3.3%. It was most commonly associated with ADHD, conduct disorder, and oppositional defiant disorder. Kids who had severe mood dysregulation, chronic irritability at wave 1 when they were about 10, were much more likely to become teenagers or young adults with severe depression versus kids who never met those criteria. So again, they didn't become kids with bipolar disorder, they became more likely to be adults with depression. This is another study, again, using that children in the community study from upstate New York, in this case, about 776 kids assessed in their mid-teens, late teens, and early 20s, showing a different association with age. So kids with chronic irritability became adults with depression. Kids with distinct episodes became young adults with mania, showing that episodes seem to matter for mania, whereas a chronic course of irritability seems to be linked to major depression. Moving beyond longitudinal studies, much of my work is involved with sort of understanding what's going on in the minds of kids literally with these disorders using special brain imaging and computerized tests. There are a lot of ways you can get into different mechanisms. You can look at the basics of emotional intelligence. Can kids recognize prototypical emotional face displays, anger, sadness, fear? You can look at response inhibition. Can kids stop themselves from doing things that are sort of impulsive? Much of my research, however, has focused on something called frustrative non-reward, which is an NIMH research domain criteria topic. A lot of jargon, but basically research domain criteria was a project developed in 2008 or so to facilitate research on mechanisms of mental health across ages and stages, across different types of disorders. But you all know actually a lot about frustrative non-reward, believe it or not. Frustrative non-reward has to do with response to block goal attainment. So it can be tested in many ways. So you can test it with rigged feedback. You can also test it with cognitive flexibility, which is behavioral response to changing rewards. And I promise I'm going to explain what these mean in common English in a sec. Starting with cognitive flexibility. So cognitive flexibility is behavioral change in response to rewards and punishment. Again, you all, for the sake of learning about this talk, are having a chance to gain some new knowledge or ask some questions, adapted your behavior, you made time. Whereas other people may not have been so flexible, and they may not have been able to adapt for rewards. Why would you look at this in kids with bipolar disorder or irritability? Well, many of the clinical symptoms of bipolar disorder suggest that cognitive flexibility is impaired. Specifically, mania. Is that a hyperhedonic increased reward period, as evidenced by euphoric mood, super happy mood, even though life around them is no good, increased goal-directed activity, excessive pleasurable activities with high potential for painful consequences without even caring about the consequences? On the other end, is depression a hypohedonic, a decreased reward sensitivity period, as evidenced by depressed mood, anhedonia or no pleasure, and worthlessness and guilt? Besides the symptoms, it's interesting to note that some of the early studies using brain imaging with adults suggested that the three areas responsible for cognitive flexibility might be changed in adults with bipolar disorder. Those areas specifically are your dorsolateral prefrontal cortex. That's an area right around my hairline currently. It's an area that has to do with executive function and planning. The striatum is your accumbens area, which has to do a lot with not just reward, but also addiction to substances. And the amygdala, and while lots of people say, well, the amygdala is implicated in everything having to do with any mental health issue, it's interesting to note that the amygdala has a lot to do with how you learn in response to negative feedback. So we started off looking at cognitive function in bipolar kids. We didn't start actually in the scanner. We started with a standard computer game, a version of the Wisconsin card sorting task, or in plain English, we put a kid in front of a touchscreen and we said, do your best. Kids very quickly figured out that if they pressed this thing that looks like a clam, it would win their points. And if they pressed the tree, it would lose points. And so very rapidly after figuring out, most kids would tend to stick to the clam. All of a sudden, without warning, the thing that was winning points now starts losing points. And the thing that was losing points starts winning points. So this is how you can objectively test cognitive flexibility. It's not just what you said in a questionnaire. We can measure how many trials it takes you to adapt. We can measure how much time it takes you to adapt. We can measure, do you stick with the previously rewarded thing in a perseverative way without adapting? In a series of studies, we showed that this construct is actually one of the few things that bipolar kids with clear-cut episodes of euphoria seem to have. So they weren't impaired across all cognitive domains, but it took them more trials and longer time to adapt to the reversed stimulus-reward association than healthy kids. And in fact, it was specific to kids with bipolar disorder with clear-cut episodes of euphoria compared to kids with severe mood dysregulation. But wait, you say life is not always so distinct. I don't always get rewarded by my boss for doing good things. I don't always get punished by the state trooper for speeding. You can actually add probabilistic feedback, meaning something is mostly rewarded, but sometimes punished. And the other thing is mostly punished and sometimes rewarded. Yet, on this different variant of the task with probabilistic feedback, the bipolar kids with clear-cut episodes of euphoria are still impaired versus controls and are still impaired compared to kids with chronic irritability, anxious kids, depressed kids, and healthy controls. But what about the brains? You said you talk about brain stuff. So as I said, a lot of adult studies showed that your dorsolateral prefrontal cortex and other areas might be impaired. We actually did one of the first studies looking at the whole brain in kids with narrow phenotype, clear-cut episodes of euphoria, and showed that all three areas implicated in cognitive flexibility, your dorsolateral prefrontal cortex on the left, the amygdala on the left, and your accumbens area on the left, were smaller in kids with narrow phenotype bipolar disorder compared to healthy kids. So we've talked about behavioral task findings showing impaired reversal learning and cognitive flexibility in bipolar kids on two different paradigms. We've talked about smaller areas implicated in cognitive flexibility, but what's going on in the minds of kids when they're actually doing this task? Well, that's where we use functional MRI. And this is me in front of an MRI scanner. Again, many of you may or may not have had an MRI. A lot of people, when we say we do MRIs in kids and the kids have to be still, they can't move more than 3 or 4 millimeters in about an hour of scanning, everyone says that's impossible. And it's actually not impossible. This is actually what we're really good at doing, is helping kids feel comfortable in the MRI. A lot of times when they're in the MRI scanner, they're actually playing video games that help us look at cognitive or emotional functioning. And they all get copies of their brain scans, and they're read by the neurologists at MGP. So it's sort of a service. It helps for some people who are curious if there's anything wrong with their brain scan. And so on the left, we're showing the first ever study of bipolar kids doing this reversal learning task in the MRI, showing that the areas we talked about, especially your frontal cortex, your dorsolateral prefrontal cortex, and your striatum, your reward areas, are different between bipolar kids and healthy kids. The graphs on the right show what is actually happening. So the healthy kids in sort of the crimson have increased brain activation when they're acquiring the stimulus reward association, when they're learning. When it reverses, it's no big deal. Their brain activity goes down. It's actually not that hard of a task. The bipolar kids in blue have the exact opposite pattern of brain activation. When they hit that reversal stage, their brain activity goes way up. It's like they've never understood this. Yet they do keep going. They don't quit our scan, which many people were worried about. On the right, the green is showing kids with chronic irritability, showing that their brain activity during this reversal learning is totally different than the kids with bipolar disorder. So take home point number 3, episodes matter. Kids with clear-cut episodes of euphoric mania, their brain activity is very different than healthy kids and different than controls. And lest you think that this is just esoteric neuroscience, an understanding of rewards and punishments really underlies all of our therapies that we use for kids. So think about basic behavior modification. If you do this, you can earn this. Maybe this is why bipolar kids tend not to improve with just basic behavior mod, because their brains aren't wired to understand how to adapt to changing rewards and punishments. Similarly, cognitive behavioral therapy, which has to do with understanding the relationship between your thoughts, behaviors, and outcomes. Generic CBT tends not to help bipolar kids, but some people have been looking at modifying it for bipolar kids. Another way of looking at bipolar disorder besides the NIMH, and there are lots of different ways to do this research, was something called the Course and Outcome Bipolar Youth Study, the COBE study. They enrolled at Pittsburgh, UCLA, and Brown kids with type 1 bipolar disorder with clear-cut episodes, type 2 bipolar disorder with episodes of hypomania lasting 4 to 7 days. They also enrolled kids who had bipolar disorder not otherwise specified, meaning somebody thought they had bipolar disorder, they didn't fit the 2 other conditions, and they created these criteria because that's the only way you can do a multi-site study. You have to have a criteria that you can get reliable on. And so they basically reduced the number of symptoms they had to fewer in number and shorter duration. And the reason this is important is because we actually had those kids play our reversal learning task, showing that in an independent sample, again, episodes matter. In red, the kids with type 1 and type 2 bipolar disorder they took more trials to learn this reversal than the kids with bipolar disorder not otherwise specified and healthy kids. Another data point shows that young adults who were followed by Brown's site of the COBE study from childhood to young adulthood, so we know their status as having type 1 bipolar disorder is not just retrospective recall, but it was actually confirmed prospectively. These young adults still have the reversal learning impairments, showing that, again, episodes matter. If you have type 1 bipolar disorder, you don't tend to outgrow this reversal learning deficit. So based on all this data, DSM-5 came out, it's hard to believe it's all 10 years ago, and some things were changed. So one thing is, to make the diagnosis of mania more specific, they added this present most of the day, nearly every day language to a manic episode. These words are copied right from a major depressive episode. So it made it more specific, because if you had a couple days during a week-long period, you shouldn't have a diagnosis of mania. You really had to have the changes of mania present on most of the day, nearly every day for a week or more. Another thing that happened was there was a new diagnosis, disruptive mood dysregulation disorder. So Dr. Liebenloff's work was not to get a new diagnosis. Dr. Liebenloff's work and my work was about testing out theories about what is or isn't bipolar disorder. But after a decade work of research, the committee said, well, if these kids with chronic irritability don't have bipolar disorder, if they do seem to be longitudinally stable in that, they created this new disorder. Importantly, in this, they have an operationalized definition of irritability that's much more specific than any other diagnosis. They defined irritability as severe recurrent temper outbursts manifested verbally or behaviorally, grossly out of proportion to the situation or provocation. It has to happen so chronically. What's chronic? At least 3 times per week, and they can't be asymptomatic more than 3 consecutive months. So again, if it goes away during summer vacation, it's not DMDD. It had to be present in at least 2 settings, home, school, or peers, and the behavior couldn't be better explained by another disorder like autism, PTSD, separation anxiety, or other things. So it's not just the new mood disorder NOS or the new irritable kid flag. It's a very specific diagnosis. And that's what take-home point number 4 of 10 is. DMDD is meant to be the most specific, precise diagnosis. It's not just a catch-all for any kid with irritability. So how can DMDD help? The hope is that this would lead to kids not being overdiagnosed with bipolar disorder if they had chronic irritability without episodes of euphoria. The challenge, though, is that while we know the pathophysiology is different from bipolar disorder, there's no real current evidence-proven new medication treatment for DMDD. So unfortunately, they end up getting put on the same medications as in the past, currently, while people are doing ongoing treatment research. So our third learning objective, how do we diagnose and treat kids with disorders involving irritability now, and then what can we do in the future with people's health? So for me, when I work clinically, and I do see outpatients, I love seeing outpatients. So I think assessing irritability, I use the same approach to a pain history that I learned as a resident, the PQRSTs. What are the precipitants? What are the triggers that lead to the irritability? What's the quality of it? How long do they last? Are there episodes most of the time? What's the quantity? How long does it last? And what kind of impairment occurs? Is it relieved by anything? How does the irritability end? Are there other associated symptoms with the irritability? Psychosis, anxiety, ADHD, substance use, autism? And then what about the time course? How does this fluctuate over time? Take home point number 6. So diagnosis is a process, not a destination. As you work with kids, getting lots of examples, understanding the worst mania, worst depression, longest normal mood or euthymia is important as you sort of use your working hypothesis to say, this is what I think the kid has now, realizing that later on, your diagnosis may change as you, as a primary care provider, know these kids best, so that even though you may start with one diagnosis, over time, it may fluctuate to something else. Take home point number 7. So mood tracking really helps getting at this issue of episodes or chronic triggers or context. On the left is something called the Beam mood chart. It has you in the column in a multicolored rainbow bar, one check mark for their mood from abnormally severe, elevated to happy mood, all the way down to severely depressed. So if it's the 28th, you put one check mark in the rainbow bar for their mood. You rate anxiety, 0 is none to 3 is severe. Irritability, 0 is none, 3 is severe, and you rate sleep. You don't have to do this forever, but a sample of a week or 2 can really help you get on the same page with the kids and the parents to understand what's going on. If you like technology, there's a free app called eMoods, which tracks the same thing, a slider for sleep, a rating of depression, elevated mood, irritability, and anxiety, and they can email you graphs of their mood so that you can really get a sense of what's going on. Take home point number 8, use medications to treat what you see. So this is an article by Argyris Stringaris, basically thinking of irritability as look at what's comorbid, what's going on beside it, and treat what you see. So for example, if they are irritable and they also have depression or anxiety, this algorithm would suggest using cognitive behavioral therapy first, and then potentially using an SSRI. On the other hand, if they have ADHD, impulsivity, hyperactivity, hard to concentrate, they would suggest sort of working with parents and kid on some behavior treatments, and then also potentially using some stimulants. So it's an interesting way of thinking about it, but the idea of treating what you see, I think, is important. This is an example of data showing how effective that can be using data from the ADHD multimodal treatment assessment study, showing that essentially combination treatment with medication and behavior modification resulted in arguably the fastest and most sustained improvement, in irritability. Take home point number 9. So therapy is the same principle of treat what you see applies. So everybody probably should get some psychoeducation to prevent relapse, prevent irritability by recognizing what are we talking about irritability, how do you recognize it early, and what relieves it. Interpersonal social rhythm therapy is something that's rooted in bipolar disorder, but again, could be useful for everybody. The idea is you're going to reduce interpersonal stress and increase routine regularity. So make sure sleep is as regular as possible, exercise as regular as possible, socialization as regular as possible. The more regular those are, more than likely, the more regular the kid's mood and behavior will be. On the other hand, when these routines start to fall off, that may be an early warning sign that things are about to get worse. Let's see. So ADHD, so lots of treatments for ADHD that are evidence proven. Creative problem solving, parent management training, parent-child interaction training, all very useful to help ADHD. In terms of mood, I talked about how regular CBT may not be perfect for kids with bipolar disorder, certainly very effective for kids with unipolar regular depression. And people are working on specific modifications for cognitive behavioral therapy. People are looking at assessing dialectical behavioral therapy, and are looking at sort of family-focused psychoeducational therapy for bipolar disorder, which actually has been shown to be very effective for bipolar kids. It's really a combination of cognitive behavioral therapy, psychoeducation, and family therapy with a lot of data behind it. Take-home point number 10, my final take-home point, hopefully fulfilling my promise to have plenty of time for questions. So there's a lot of opportunity and real need for clinical and research collaborations to move the ball down the field in terms of what we know about irritability, its mechanisms, and how to treat it. There have been regular NIMH-sponsored conferences about irritability, going all the way through the initial start of the pandemic, and obviously the pandemic has gotten in the way of some of this, but it's been the subject of the presidential initiative of ACAP, the American Academy of Child and Adolescent Psychiatry, as we're trying to learn more about irritability. The big gaps have to do with characterizing the temporal patterns and severity beyond just episodic and chronic. What about the missing quadrants of episodic irritability and sustained euphoria? Assessments. How do we use real-world assessments and questionnaires? How do we use big data medical records to advance what we know about irritability? What about associated patterns from ADHD, autism, anxiety, regular depression, and even borderline traits? And then understanding, again, more about the biological mechanisms and what treatments do or don't work for which kids. That's really kind of where my own program and my own work in an ongoing way comes in. So I really do believe in trying to make sure the Gabbies of the world, the kids struggling with mental health issues, can have as good of an outcome as the Jacks of the world that have cancer. Again, to me, that just seems fair. And while childhood cancer is no longer in our top 3 causes of death of kids, suicide is the second leading cause of death, starting at age 10 to age 34. And so better understanding of the mechanisms of these disorders, I think, matters to the families with which we work. Trying to do a better job understanding bipolar disorder, irritability, self-injury, and suicide with earlier, more specific diagnosis, targeted treatments and outcomes. And we're doing a study right now of 8 to 16-year-olds with any amount of irritability, from none to tons. You can learn more about that at our pdmind.org website. So I don't care what their diagnosis is. Honestly, as long as they don't have braces, they're welcome in our study. And again, they can't have braces because we do MRIs. But fillings are okay, other things are okay. The idea of this better mechanism is not just pie in the sky stuff. So we're essentially trying to go with brain-based diagnosis. So instead of going DSM silos, what's the difference in brain pattern, which I've done and other people have done. In this case, we're trying to look at kids across the range of irritability and say, okay, looking at brain function, how does that brain function map onto symptom clusters of irritability? The benefit of this could be more specific diagnosis, could also be novel treatments. So, could we, if we find that certain patterns of dorsolateral prefrontal cortex brain function is altered in kids with this pattern of brain function, could we essentially retrain their brain? Could we help them be more aware of their getting out of control? This is actually a picture of my kids about 8 years ago wearing wearable FNIRS brain monitor activity, and they're sort of testing this out. These are Bluetooth wearable things that we're thinking about using for research, showing that kids, they're thumb wrestling, kids doing other stuff, we can measure brain activity. So if we understood more the brain marker, we actually could use that to develop novel ways to assess, diagnose, or treat. Again, not saying they have mental health issues, just saying they were willing to sort of pilot this interesting way of looking at brain activity, that it's not just pie in the sky stuff, that they could walk around my office, interact, and show that we were measuring brain activity. So in conclusion, irritability is a big problem. It's common, it's non-specific, and bad. While irritability comes in many flavors, much of the research of the past decades comes from bipolar disorder. Episodes matter. They're worth asking about. Does a kid have 4 to 7 days or 7 or more days of, abnormal super happy mood, abnormal super irritable mood, abnormal super sad mood? This includes DMDD, which is not meant to be the catch-all replacement for mood disorder NOS or any kid with irritability. If they have a known cause for irritability, including depression, ADHD, autism, it's not DMDD. Number 6, let your diagnosis evolve as you work with a child. Number 7, mood tracking is very helpful to determine the time course, triggers, context, and associated symptoms of irritability. Number 8, use medications to treat what you see. Number 9, that applies for therapy too. And number 10, we're all in the same boat. If we can partner together, just like people did for childhood cancer, where providers, parents, researchers all got together and said, enough of our kids dying of cancer, let's do research, let's move the ball forward on our clinical approaches to cancer. If we could do that for kids with mental health conditions, think about how better our world would be, think about how much better our families would be doing. And with that, I just want to thank everybody for joining, again, especially on a snowy day. Especially when you have lots going on. I appreciate your coming together to learn more about irritability in general, plus the ways that we can all partner together to improve things. Thank you so much.
So don't go yet.
I won't.
I'm talking to the audience. I know you won't, Dan. Thank you so much. This is fantastic. And I think we can have some really good conversation as well for another, 10 or 15 minutes. So one question that has come up in the question and answer box, I'll read to you. And it says, are you doing research about how socioeconomic status, racism, caregiver mental health impact irritability and how it might inform treatment options?
That is a fabulous question. And the answer is, not only are we doing it, but lots of folks are doing it. So for example, while we have a lot of focus on brain behavior mechanisms, understanding context really matters. So we have been looking at things like socioeconomic status, recently food insecurity. We actually have a data set that we're working on publishing as we speak about food insecurity in relation to irritability. Certainly, as of about 2 years ago, in the larger context of what was going on in the US, we added measures about perceived discrimination and bias to our studies that we're approaching having enough sample to actually do some analysis. But 100% context in which the kid grows up definitely matters. That's also why in our studies, we don't take anybody's word about the symptoms or what's going on as the absolute truth. So in all of our studies, we get kids' sense of what's going on, we get parents' sense of what's going on, not just cross-sectionally, but we actually have some interesting ways to do what's called ecological momentary assessment, or in other words, doing mood tracking with a smartphone app, where we in our group are actually uniquely looking at what the kid says about their mood 3 times a day for roughly 1 to 2 weeks over time, and then also what the parent thinks is going on with the kid, again, 3 times a day for 1 or 2 weeks to look at the synchrony of kid and parent reports versus the asynchrony, meaning where they disagree, because that's as much of a learning opportunity as when they do agree. It's a great question.
Yeah, I agree. I think that's a fantastic question, and I would just add that you've done such a nice job, Dan, in translating some of the research on biomarkers and imaging and behavioral paradigms for measuring irritability that shows such a clear demarcation between episodic bipolar disorder, with irritability that occurs, in the middle of an episodic state versus chronic irritability. I think the chronic irritability is something that it sort of ends up being so much more ecological, if you will, and when you look at irritability as kind of a lack of learning how to cope with frustration and with negative experiences, that you bring in all of the understanding that we have about trauma, about environmental conditioning, and a failure of learning how to self-regulate, that and I think the ecological context becomes even more important, although it's still important for the episodic bipolar as well. But that's a fantastic question. Let's see. I'm looking for other questions. Yes, the slides will be available on the website, and definitely keep that in mind. I'll ask a couple of questions. So Dan, you mentioned that CBT might not be as effective for bipolar disorder when you have the episodic bipolar disorder. And I'm wondering if you could clarify this a little bit, because I'm worried that people might kind of come away with the notion that it's ineffective as opposed to less effective. And I wonder if you can clarify that.
So I think it's a great question. So I think so CBT is wonderful for unipolar major depression. It's wonderful and very helpful in many ways for anxiety. There have been a couple studies, again, not a ton, but a couple studies showing that generic CBT, the same kind you would apply for major depression, may not be as useful for the bipolar kids. However, there have been some studies showing that if you modify it, so what are the modifications? So one of the modifications, again, in some ways, the Miklowitz studies of family-focused therapy is really CBT given to groups of bipolar kids that has a lot more training in helping the kids and the families recognize the warning signs of both mania and depression than you would get in standard CBT. So that's an example of how it can be helpful, but in some ways, because in some ways it bridges the brain studies that we're doing, where you see the bipolar kids don't have this sort of brain circuitry built to adapt in response to rewards and punishment. In some ways, maybe that's why they need this extra dose, this increased amount of training in what are the warning signs of mania, what are the warning signs of depression, far more than you would give somebody with depression. So I think that's what I mean. Family-focused therapy, for what it's worth, I don't know how many of the audience know about it. It's interesting. It's one of the best evidence-proven treatments for bipolar disorder in kids that is probably the least widely known about. While Dr. Miklowitz has written books and many articles about it, it's not one of those therapies that most psychologists get exposed to, unfortunately. And so that's why, again, you can definitely, I mean, we have the slides have the references if people have questions, because it's not that hard per se to do. It's just not widely disseminated for reasons that I can't speak to. But yeah, I do think that, again, CBT can be amazingly helpful for regular depression and anxiety. You just need to sort of tweak it for kids with bipolar disorder, at least so far, possibly because of these brain mechanisms. But again, I can't say that that's exactly causative.
Thank you. That's great. Yeah, I wouldn't want people to come away with a notion, which I'm sure you weren't meaning to imply, that kids with bipolar disorder can't really learn, how to regulate. But it certainly is not as readily possible to just simply, introduce, these incentivization paradigms and sort of, kind of consequences, to and then to expect, that the behavior is going to change, under those conditions, which I think is a great point.
I would also, I mean, I guess on that note, I would also say I wouldn't want people to come away from this saying that bipolar kids can't learn in general, right? I think that while we showed that it takes them longer to learn this construct, and while there are data showing that bipolar disorder does certainly impact kids' functional ability in school with peers, what might happen beyond high school. It's not to say that kids with bipolar disorder aren't smart. It's also not to say that kids with bipolar disorder, can't learn. I think it's interesting, having done this research, people have lots of stereotypes about what bipolar disorder is and isn't. Are these kids just sort of, Tasmanian devils, really kind of hellions? And the answer is they're not. They're wonderful, sweet kids as any other kids, but when they're in the middle of depression, when they're in the middle of mania, they are really struggling, and sometimes it's very hard to get them out of either of those poles of mood state.
Absolutely, absolutely. Dana, I wonder if you could speak to the role of alpha agonists for irritability. The sort of particularly the non, episodic bipolar type, because that wasn't one of the medicines that showed up in your algorithm. Yeah.
Yeah, I mean, so I think if memory serves, there have been one or two studies of alpha agonists. I think alpha agonists can, in particular for kids with ADHD, can dampen down, slow down some of the hyperactivity. And so there may be a role. The other thing I didn't really get into about stimulant choice for ADHD, so and irritability, very interesting meta-analysis that came out about 6 or 7 years ago, I guess, accounting for pandemic, 3 years, looking at, does it matter what stimulant you're put on in terms of irritability, showing that actually it does matter for kids with ADHD, that methylphenidate stimulants had far less irritability than dextroamphetamine stimulants. That's something that I can make sure is in the slide, but that's one of those things that I know clinically when I do consultations or see people, if a kid's being treated for ADHD and they're on a dextroamphetamine stimulant and they're having a lot of irritability, that's one of the things I'll try. I'll try switching them to a methylphenidate-based stimulant. And I wouldn't say always, but I would say a lot of times that actually makes a big difference. And it's not just a short term, like the first week was fine and then everything reverted. So that's something where the data matters about irritability.
Yeah, that's interesting. And I don't think that study has been well publicized. So I don't think many people are aware of that, and that's really interesting. I'll add that for one of the diagnostic groups, that kind of encompasses these kinds of kids with the chronic, sort of trait like irritability, is oppositional defiant disorder, and I think that guanfacine, particularly one of the alpha agonists, has been kind of considered to be one of the first line treatments for kids with these kinds of presentations, but definitely it's not well. I don't think it's a extremely strongly supported pathway, but it's certainly a relatively benign pathway in terms of avoiding potentially scheduled medications and things like that. Yeah, so Dan, I wonder if you could speak to DMDD, because you mentioned how the DSM-5 sort of has come up with DMDD, and what do we make of that category? It's probably one of the more controversial additions to the DSM-5, And I'm sort of wondering what your take is on that. Would you encourage the use of that diagnosis for these irritable kids?
Yeah, so I think that I guess the two things I would say, well, maybe three things. So one is, as I said from the outset, the goal of Dr. Liebenloff's research and my research wasn't to make new diagnoses, right? The goal was to test out controversies with data, to replace dogma with data and say, are kids with chronic irritability the same or different as kids with episodes of euphoria? When we started that study, actually that was my project as I was a postdoc, believe it or not. I finished my triple board residency. I went to NIH. I was going to learn about brain imaging and irritability and euphoria. And I was the postdoc who was helping Dr. Liebenloff start the kids with chronic irritability study, because the kids with narrow phenotype bipolar disorder study had started about 2 years before I got there, and I remained involved with that. And we didn't know if they would exist. So they did exist. It was not a research line that was meant to make a new diagnosis. The new diagnosis came from the DSM-5 committee looking in and ingesting new data, about a decade's worth of data, showing that brain longitudinal course symptom response was different in these kids, and they decided to make the new diagnosis. So I think the main thing, so one is we didn't start out making a diagnosis. Two is it really is not meant to be the irritable kid catch-all diagnosis. I think that's the concern that I and others have, is it wasn't just to replace mood disorder NOS or bipolar NOS with another term. And so I think that's where I see problems coming, that people say, oh, irritable kid, that's DMDD, because it's not. And the result of that potential misdiagnosis is that it might mean a kid's not getting the right treatment, right? So knowing that if they have ADHD and they get irritable in relation to their school behavior, or to they can't wait for their reward or whatever, and with a proper diagnostic eval, saying that kid has DMDD rather than saying that may be a kid with ADHD, that would not help that kid. That would be a disservice to that kid, that, the result might be that they might get put on medicines that aren't as effective for what the kid has. So I think that being careful with that diagnosis, avoiding the rule outs is super important, including, again, depression, ADHD, autism, I would say, are the most common things where people apply DMDD where it shouldn't, sometimes because they may not have looked at the criteria. And again, most people don't read DSM, and I'm not saying it's riveting reading, but I do think it's worth looking at the criteria for the disorder before you apply it. I think the second thing is, particularly with autism, I think sometimes this diagnosis gets applied because of our very strange billing habits, right? So like in certain settings, you can't bill for autism, whereas you can for DMDD. And that's something where I completely don't really understand the systems. I've asked lots of people, maybe you would know better than I. I'm told that we can't bill, like, for example, inpatient for autism because it's a chronic condition. But then my question is, well, isn't everything really a chronic condition? I think for better or for worse, so much of our healthcare shows that it's a chronic condition. So I don't know that that should really hold water.
Yeah, no, I agree with you. I wish I had an answer to that, and I don't. But I think we sort of learn as we go with billing and stuff like that. But one way that I think about irritability, I wonder if you could speak to whether you agree with this or not, is I kind of think of it as like a fever, in a way that it doesn't sort of mean that, it doesn't have any meaning as an illness, but it is certainly something that kind of carries with it the need to find out, what's wrong, and so that what's wrong might be bipolar disorder, might be ADHD, it might be PTSD, it might be autism spectrum disorders, but it's something really important that no one would sort of see a child with a fever and say, oh, nothing to see here. It means that something's going on, but it's not anything specific. I wonder if you agree with that.
Yeah, I would definitely agree with that. And I think in some ways that's also part of why trying to combine sort of, brain imaging stuff with practical tips, understanding how you evaluate a fever to be methodical so you don't miss certain things, so you don't just either blow it off or say, oh, fever, that means they have cancer. I mean, that's not true for most people. You need kind of a rational approach to it, which is why for me, understanding what's the irritability associated with, what's its time course, leveraging information from kid, parent, maybe educators, leveraging stuff about mood tracking, not forever, but like a week or so of data can really get you pretty far down the road of figuring out, what the irritability is, just like, again, your example, which is right on of what the fever is. I very much agree with that.
Well, Dan, thank you so much. It's a fantastic presentation. Just a privilege to hear about all your research and to have all these great teaching points. Especially endorse the BEAM mood chart, not only for diagnostic purposes, but for kind of monitoring as you go along. Because once you use measures like that, you can really see, whether things are getting better, over time, and it's really helpful for the patient and the family to see that too, because it can be hard to kind of find your way through the fog, when these things are going on. But wonderful, thank you so much. Thanks to the audience for bearing with us and for your attention. And we'll look forward to seeing everyone next month.
Thanks for the opportunity. I hope everybody has a great day.
Thank you so much.